छोटा टॉपिक है, अराउंड 5 to 6 पेजेस है। जो रिलेवेंट है वही ग्रास्प करो, बाकी का छोड़ दो। इफ यू वांट टू ऐड समथिंग प्लीज टेल मी इन बिटवीन। So topic is metastatic cancer to lung. Out of 100 patients, only 20% of them are symptomatic. Most common would be cough or hemoptysis, and the symptom will tell you where the lesion is located. For example, it is located very close to the airways, and invasion of airways then present with cough. If hemoptysis, it says that it is located close to vascular structures or it is eroding them. So, per se, true endobronchial mets are rare, but can be seen in breast, thyroid, melanomas, RCC, and colorectal diseases. चेस्ट पेन का मतलब होता है चेस्ट वॉल इन्वेजन है। डायग्नोसिस हमारे पास यूजुअली वही है, सीटी, एमआरआई, पेट, मगर कौन सा कब करना है विल टेल यू। लो डोज सीटी शुड बी डन एज द इनिशियल मोडालिटी, बट मगर if the time between the surgery and the recurrence is very short, DFI is very short, go for PET CT. MRI का रोल होता है when it is involving soft structures like heart, major great vessels, or chest wall invasion, or neurovascular bulges like spinal brachial plexus, and also to at the same time to rule out liver mets, synchronous liver mets. CT पे
sorry to interrupt. ये लो डोज सीटी के बारे में कुछ किसी को और कुछ आइडिया है, डिफरेंस बिटवीन लो डोज सीटी एंड एचआरसीटी?
नो सर,
any idea? कुछ मैं क्वेश्चन सुना था बट आई फॉरगॉट। देयर इज सम डिफरेंस एचआरसीटी इन लंग्स, व्हाट इज लो डोज सीटी?
सर उसका नोट्स है पीएलसीओ ट्रायल का है ना, लो डोज सीटी का
कुछ है। हाँ, ऐसा कुछ है, कुछ
उसका है सर। उसका रेडिएशन डोज इज समथिंग अराउंड 150, उसका ऐसा आसपास है सर। मेरे पास फोटो है, आई विल शेयर यू विद दैट नोट्स का, पीएलसीओ ट्रायल का। ठीक है सर,
फाइन। It is different from HRCT, if I'm not.
yes sir. तो सीटी
सर मत बोल भाई, हम कलीग है भाई। सर लग के लगता है एग्जाम में जैसे भाई।
तो पूछ रहा है तो ऐसा लग रहा है कि
just discussion भाई, मतलब दिमाग में है सीटी। Okay, sorry, continue.
Okay, CT appearance of pulmonary vents. Usually they can be peripheral or central. They are well circumscribed, smooth surface, and we call them as cannonballs. Okay, next page, please. That lung lesion, the differential diagnosis can be usually whether it is single lesion or multiple lesions. Suspect always primary or metastasis from the elsewhere if it is single or multiple lesions. But for multiple lesions, we have other DD like infectious process also. Okay. So, what is the probability of that lung nodule to be a primary lung lesion or metastatic lesion based on primary cancer? If it is there is a history of sarcoma or melanoma, there is 10-fold increased chance that the lesion can be metastatic rather than a primary lung cancer. Whereas genitourinary and colorectal, equal chances that lesion can be either primary lung cancer or metastatic diseases. For head and neck cancer, the chance of metastatic lesion is rare. That lesion can be primary lung cancer only, twofold increase in the risk. So, for patients with non-small cell lung cancer, after metastectomy, they have unique kind of recurrence. That is, risk of recurrence is 6 to 10% per year, but it decreases to 2% thereafter. It's risk of recurrence after metastectomy. Whereas the risk for the development of second primary is 3 to 6% per person per year, but ये कम नहीं होगा. This is constant and will increase. Whereas recurrence will decrease, whereas chance for development of second primary is same and it increases. Okay. After curative resection, new primary lung cancers are more likely to develop after 4 years and usually have a classic radiological appearance. Speculation are mixed solid and ground glass opacity. Those models दिया हुआ है like risk prediction for lung cancer of the specific nodules. दो मॉडल्स है, BSH मॉडल है, फुल फॉर्म मैंने देखा नहीं. एपिकैन मॉडल, इसमें है एज, smoking history, asbestos history, and sex, and it predicts that nodule, how much that nodule can be a primary lung cancer rather than a metastatic disease. सो ट्रीटमेंट मोडालिटी हमारे पास है सर्जिकल, नॉन सर्जिकल. सर्जिकल मोडालिटीज में है which is gold standard metastatectomy. So this was first given by Ehrenhaft et al. This criteria was established by Ehrenhaft et al. Later modified by Thomford et al. इसमें 5 criteria है which is definitive control of the primary disease or at least possible to control the primary disease and absence of extrathoracic metastatic disease or ability to control it. The possibility to achieve R0 metastatectomy and the ability of the patient to tolerate the planned procedure, and there is no other better treatment option available for them. In such cases, surgical resection can be performed. ये नीचे जो है ना इंटरनेशनल रजिस्ट्री फॉर लंग मेटास्टासिस, ये 3 क्राइटेरिया दिया है. दिस होल्ड्स फॉर ऑल अदर थिंग्स लाइक आई विल टेल यू. In decreasing order of frequency of primary tumors is soft tissue sarcomas, osteosarcoma, colorectal cancers, breast, RCC, melanoma and head and neck cancers. ये है. तो
म्यूट करो सब लोग भाई.
विशाल प्लीज म्यूट इट. विशाल ओके थैंक यू. अकॉर्डिंग टू देम 3 फैक्टर्स है. वो है whether you can achieve R0 resection, what is the DFI and how many lesions are there. ये 3 criteria के ऊपर में बाकी का पूरा rest of the class depends. So according to their registry, overall survival after pulmonary metastatectomy 5 years का है 36%, 26% and 22%, 10 and 15 years respectively. अगर if they have achieved R0 resection, R1 and R2 it is less. So, what are the factors that influence the long-term survival are in diffuse disease-free interval of greater than 36 months and single or multiple mets. If it is single mets, 43%, multiple mets है तो decrease हो जाएगा. Based on these 3 factors, patients are categorized into 4 groups. Based on these factors, one is disease resectability, single or multiple mets, DFI was 36 months. If they fit into all these favorable factors, 5-year survival is greater than 50%, and they are unfavorable. 5-year survival is less than 15%. The second metastatectomy shows survival rate of 45%. So procedure open versus minimal invasive. वैक्स का एडवांटेज ये होता है कि शॉर्टर पेन, शॉर्टर स्टेज, लेस पेन, अर्ली रिकवरी एंड अर्ली time of starting the chemotherapy and better tolerability and better pulmonary function tolerability. Open has its own advantage when the lesions are very small, which cannot be visualized with wax. This criteria was given by Cerfolio et al., where we have some factors when to do wax and when to do open surgery. Size of the lesion, first number of nodules. If the number of nodules are 1 or 2, wax is proposed. 3 or greater than 3, open. Size of the nodules, largest should be greater than 5 centimeters, then you can do wax. Less than 5 centimeters, open. Size of the smallest nodule, if it is greater than 1.5 centimeters, propose wax. Less than 1.5 centimeters, open. So location, peripheral wax, central open. Histology, colorectal के लिए तुम wax कर सकते हो, whereas melanoma you cannot do wax. Pulmonary function test, marginal and normal. Past history of radiotherapy, if it is there, open is better preferred and avoid wax. Lobar location, upper and middle lobe you can offer wax. For lower lobe, offer open surgery. Approach, open metastatectomy can be unilateral, bilateral. Unilateral thoracotomy, bilateral we have 3 options. One is medial sternotomy. इसका problem होता है कि posterior exposure is very poor and lesions on the left posterior aspect cannot be assessed and palpated easily. Difficult होती है. Another one is clamshell incision, which is a subcostal bilateral incision with it gives good visualization of both the lungs, especially lower aspects of the both lungs. Another one is sequential thoracotomy, which is more popular. ये इसमें करते हैं कि on one side you operate, after 3 to 6 days you operate on the other side. So lymph node dissection in case of pulmonary metastasis, एक फैक्टर इन्फ्लुएंस करता है मेनली, दैट इज नंबर ऑफ pulmonary metastatic nodules. If it is more than one, it should be done बोल के दिया हुआ, like study by Frank Smith et al. He has operated on 245 patients with mediastinal lymph node dissection, and he has seen that 1/3 of the patients will have mediastinal lymph node positivity. In that also 50% will have pulmonary and hilar lymph nodes, the rest 50% are mediastinal lymph nodes. So according to him, what is the median survival? If there are no nodes, it is almost 64 months. Pulmonary है तो 32 months, mediastinal है तो और कम है 20 months है. So any patient with mediastinal nodes is a poor prognostic factor. So in those cases, if the patient has mediastinal lymph nodes, do not do radical surgery. Do as minimum as possible, because it is not going to give much survival benefit, and it also gives extent of resection. Approximately 50% of the patient post metastatectomy will recur. So better to do non-anatomical and preserve as much as pulmonary tissue as much as possible to preserve the physiological function. Next. So whether to do veg resection or lobectomy, pneumonectomy. Peripheral lesions है तो non-anatomical veg resection करना है rather than anatomical veg resection. It improves the post-op lung function. So lobectomy कब करना है? पर pulmonary meds, there is no data to suggest when to do lobectomy, but it can be done when there are multiple lesions in the same lobe. When the lesion is located deep and towards the center, where non-apical dissection is not possible, when the lesion is involving the airways or vascular structures. Okay, pneumonectomy कब करना है? When there is long disease-free interval, good performance status, and centrally located lesions. Okay. Ablative therapies for metastasis. We have SBRT, SABR, percutaneous like RFA, microwave and cryo. Pulmic trial है pulmonary metastasis में colorectal metastasis. ये बोलते हैं कि सर्जरी भी कर सकते हो and non-surgical procedures भी कर सकते हो. The both can be done as a therapeutic options. So RFA and microwave ablation. RFA we can offer to those patients if the lesions are present in the outer 1/3 and middle 1/3, and mechanism of action is protein degradation, coagulative necrosis है. Temperature should be greater than 60 degrees centigrade, and the problem with this is this heat shrink effect कुछ रहता है ना, so and 100% of the treatment is not effective because of the impedance from the surrounding structures. So size of the lesions to which this RFA can be given is up to 3 to 3.5 centimeters. ठीक है. Needs multiple application, less efficacious near large blood vessels, not recommended adjacent to central airways. So microwave ablation can be given for lesions greater than 3 centimeters, which are located deep also, close to blood vessels and airways. Its efficacy depends on the water content of the lesion. It is not affected by surrounding aerated lung or vascular structures. Uses higher frequency than radio frequency ablation. Large areas can be treated compared to RFA. With percutaneous ablative techniques, okay. Median OS is almost 50%. Next. Treatment concerns and outcomes for individual histologies. First is soft tissue sarcomas and osteosarcoma. Soft tissue sarcomas, peripheral limb sarcomas, most common site of metastasis is lungs. As most of the soft tissue patients are younger patients, gold standard for them would be metastatectomy. Reason is because of the good performance status, good pulmonary reserve. And 5-year survival rate in these patients after metastatectomy is 30 to 40%. And whenever we find a new lesion or nodule at the site of surgery on the ipsilateral side, unless otherwise proved, it should be considered as a recurrence. Okay. If the patient doesn't go metastatectomy, the anticipated 3-year survival is only 17%. there is no significant difference in survival is observed between patient managed non-operatively and patients undergoing incomplete resection of disease. So prognostic, okay. What are the good prognostic factors that improves overall survival after metastasectomy? मैंने बोला ना वो याद रखने के लिए 3 पॉइंट्स इंटरनेशनल रजिस्टर ऑफ लंग मेटास्टेसिस वही है यहाँ पे DFI should be greater than 2.5 years and single lesion and R0 resection low grade. Okay. After metastectomy, if the tumors are sensitive to chemotherapy, they should be given with chemotherapy. They have good survival. Recurrent metastasis to lung should be offered surgery if performance status is good, as chemotherapy is insensitive. Next comes melanoma. Melanoma, it can be disseminated melanoma or isolated pulmonary mets to pulmonary mets. In case of disseminated melanoma, overall survival is less than 6 months. Whereas isolated pulmonary mets, 5-year survival is 9 to 35%. Okay. And isolated pulmonary mets, metastectomy, median survival is 20 to 40 months. Factors associated with poor survival after metastectomy in melanoma are lesion greater than 2 centimeters, multiple lesions, DFI less than 36 months, incomplete resection. Same way here, DFI less than 36 months, R0 resection not possible है, single lesion लिए, multiple lesion है. One additional factor is size greater than 2 centimeters. बाकी का कुछ नहीं है. Next page. Renal cell carcinoma, most common site of metastasis is lung, and they are diagnosed at the time of presentation or after nephrectomy. At presentation, if it is at presentation of nephrectomy, if it is a systemic disease, start with systemic therapy like cytokine therapy, interleukin 2 or interferon alpha or vascular endothelial growth factor receptors. Pulmonary metastectomy in selected patients demonstrating response to chemotherapy, systemic therapy. Before the targeted therapy is available, the factors that are favorable for metastectomy are R0 resection, size of the lesion less than or equal to 3 centimeters, lack of pleural effusion, negative mediastinal lymph nodes, and less than or equal to 3 lesions. In RCC, mediastinal lymph node dissection should not be performed radically or should not be performed because overall survival is not going to change whether you perform or not. Pazopanib, multi-targeted vascular endothelial growth factor receptor, is being under study for patient after complete surgical resection of all metastatic disease. In the presence of targeted therapy, metastectomy should be performed when there is a long DFI, very good response to systemic therapy with targeted therapy or immunotherapy, and lesions are very small, peripheral, and accessible. Whereas in case of breast cancer, isolated pulmonary metastectomy 5-year survival is between 30 to 50%. वही same 4 factors है. DFI should be large, R0 resection possible, lesions should be less than or equal to 4, and the most important is hormonal receptor positivity. They will have poor prognosis even if all these factors are present and it's hormonal negative. Coming to germ cell tumors, non-seminomatous germ cell tumor will have mediastinal lymph node involvement. In them, the best treatment is chemotherapy followed by metastatectomy. Next page. Chemotherapy is best followed by metastatectomy. They have median overall survival of 24 years with 5-year survival of 79% and 10 years of 73%. And the prognosis and adjuvant treatment is decided by the histopathology post metastatectomy. अगर इसमें necrosis है, it is a good sign. Teratoma is present, good sign, and they do not require any additional treatment. Other, if there is a residual disease present in that lesion, it needs adjuvant chemotherapy, additional chemotherapy. So when do you perform mediastinal dissection post chemotherapy non-seminomatous germ cell tumor? 4 conditions है: gross residual disease, partial response with recurrence or increase in size while the patient is on chemotherapy, relapse after second line of chemotherapy to determine the response to therapy. Poor predictors after surgery होती है 3 factors: patient, elderly patient, increased serum markers before the chemotherapy, and incomplete resection. Colorectal cancers, Colorectal cancers with lung mets, it is around 5 to 15%. They have a good survival of 30 to 40% post metastectomy. Pulmic trial compares active monitoring to active monitoring plus pulmonary metastectomy, can be either surgical or ablation. Poor survival factors after metastectomy are short DFI, multiple mets, positive hilar lymph nodes, pre-thoracotomy, high serum CA levels. In this analysis, presence of liver mets did not define the prognosis. Histological findings that influence overall survival in metastatic specimen include lymphovenous invasion or pulmonary pleura involvement or ASFC. Aerogenous spread clusters of pre-cancer cells. Out of these three, lymphovenous invasion and ASFC will predict the survival. 5-year survival without this is 85%, with them it is 46%. Both the cases almost. After metastectomy, recurrent lung recurrence predictors as after greater than 3 months at first metastectomy, shorter interval between surgery and first metastectomy. These two factors will decide the recurrence, second recurrence. बस उतना ही है.
हो गया.
कुछ आया समझ में?
अच्छे नोट बनाए भाई, ऐसा ही चाहिए, छोटे छोटे टू द पॉइंट.
शॉर्टेस्ट उसमें पूरा उठा के जो मेन था वही देता है मैंने.
And it accounts for around 10% of cancers. 50% of all 50% of all colorectal cancers develop liver metastasis. या तो वो synchronous हो सकते हैं metachronous. Synchronous disease is in 15 to 25% of these patients, and metachronous is 75 to 85% of these cases. Definitions. ये एक एक्सपर्ट ग्रुप ऑफ ऑन्कोसर्जरी मैनेजमेंट ऑफ लिवर मेटास्टेसिस करके एक ग्रुप है जिसने टर्मिनोलॉजी दी थी that there is synchronous disease which is detected at or before diagnosis of primary tumor, and metachronous is further divided into early and late metachronous. Early metachronous is within 12 months after diagnosis of surgery, and after surgery or diagnosis, and late metachronous is after 12 months. Investigations क्या क्या करने हैं? Investigations, ultrasound has a limited role in pre-op evaluation. Obviously, sensitivity is low, 64% for colorectal liver metastasis. However, a contrast enhanced ultrasound है. This characterizes liver lesions based on dynamic assessment of tumor vascularity. Has a higher sensitivity comparatively, 80 to 90%. Intraop ultrasound का function is only intraoperatively mapping of the major vessels and lesion detection करना. Intraop ultrasound use करने से there is an additional advantage that there has been data of identifying new lesions in approximately 16% of cancers of what we earlier knew, and clinical management has been altered in 9% of cases. And further combining all of this is contrast enhanced intraoperative ultrasound. So this is helpful this has higher sensitivity and specificity than traditional intraop ultrasound, and this is majorly helpful for disappearing lesions in the patients जिनमें neoadjuvant chemotherapy के बाद the lesions गायब हो जाते हैं. ठीक है. Next, CT abdomen. CT abdomen में we see these metastases in the portal venous space, that is approximately after administration of contrast agent, and detection rate जो है 85% है CT का, positive predictive value 96% है. So ये जो colorectal liver metastasis है, they are typically hypovascular, variable heterogeneity होती है, and depending on size and previous treatment. So colorectal liver metastasis that are less than 10 mm, मतलब 1 centimeter से छोटे, are too small to characterize by CT. और fatty liver post chemotherapy जो है, they can further limit the detection of liver metastasis. MRI is helpful in detection and characterization of colorectal liver metastasis जो हम CT में नहीं ढूंढ पाते, that is less than 1 centimeter वाले. MR में they are T1 hypointense, T2 hyperintense, heterogeneous, but REM enhancement होती है in the arterial phase and hypoenhancement in the portovenous and delayed phase. So there are two advances over MRI. अभी MRI में for colorectal liver metastasis that are diffusion weighted and hepatocyte specific contrast agents. ठीक है. So ये diffusion weighted से क्या फायदा होता है? They improve sensitivity and specificity for lesion characterization, and जो specific contrast agent है, that is hepatocyte specific contrast agents, they are highly sensitive for detection of small lesions जो कि virtually occult होंगे on other sequences. ये जो specific contrast agent है, that is gadobenate, dimeglumine and gadoxylate disodium. बोलना भी नहीं आ रहा मुझे. So this allows for detection of disappearing lesions which can mimic complete response in neoadjuvant chemotherapy. So हमने अभी तक what we've learned is disappearing lesions में there are two things that can help, that is intraoperative contrast enhanced ultrasound and MRI with this hepatocyte specific contrast agent. PET CT less sensitive है but more specific है. Smaller lesions that is less than 10 mm वाले and liver metastasis from some mucinous adenocarcinomas can be missed even in the PET CT. So less than 10 mm वाले में only MRI is helpful. PET CT and CT, both of them can miss them. And most of the guidelines that recommend PET are the ones that actually recommended for the evaluation of extrahepatic disease. So when we do a PET CT to rule out extrahepatic disease, they might be found in as high as 32%, and they can lead in change in treatment plan. So there are risk scoring systems. So this was a seminal paper, that is a Fong ka. So he gave a clinical score for predicting recurrence after hepatic resection for metastatic colorectal disease. Okay, so iske baad aaya tha Fong score. So Fong score had 7 parameters which were found to be independent predictors of unfavorable prognosis. First one being presence of extrahepatic disease, positive resection margin, nodal metastasis associated with primary colorectal cancer, disease-free interval of less than 1 year, largest liver metastasis greater than 5 centimeter, more than 1 liver metastasis, and serum CEA levels greater than 200. So Fong score was composed of all these 7 parameters, and इनमें से जो last 5 parameters है, that is nodal mets, DFI, 5 centimeter से बड़ा tumor, more than 1 liver mets, and CEA. These were used in a pre-operative scoring system, 1 point of each criteria, and the total score जो निकलता था, that was highly predictive of the outcome. So no patient with a score of 5 or more was found to be a long-term survival. So इसके बाद after Fong score came the game score. Game score is genetic and morphological evaluation. इसमें genetic factors भी include हुए थे. So they added KRAS mutation. इसमें CEA of more than, I think it should be 200, it is 20 in this. And nodal positivity, tumor burden score they wrote 3 to 8, which was given a score of 1, and tumor burden score of 9 or more should be given a score of 2. Extrahepatic disease, and total 7 points होंगे इसमें. So low risk was 0 to 1, intermediate was 2 to 3, and high was 4 or more points.
ट्यूमर बर्डन स्कोर कैसे डिसाइड कर रहा है ये लोग?
क्या?
अरे तुम बोल रहे हैं ना ट्यूमर बर्डन स्कोर 3 to 8 होगा तो 1 और 9 और मोर होगा तो 2, तो ये ट्यूमर बर्डन स्कोर कैसे आएगा?
देखना पड़ेगा. I think we can look for it. उनमें अलग पैरामीटर्स कुछ होंगे.
ओके,
मैं ढूंढ के बता दूंगी. So 5-year overall survival जो low risk आए थे उसमें 73% है versus intermediate में 50.6%, और high में जो है 11%. So this was found to be a significant difference. So there was another study which validated this game score, और उसने compare किया था colorectal liver metastasis patients को 2 cohorts में at John Hopkins and MSKCC. They compared the game score and the previous CRS score, and they found that the game score was superior to the CRS score, and it had a potential to replace the latter. So abhi tak whatever we studied, the points to note are synchronous metastasis have worse prognosis. If there is metastasis to portal lymph nodes, they have a very poor prognosis. This is found in approximately 3 to 30%. If there is a progression on preoperative chemotherapy, it has a very poor prognosis, and 5-year survival of only 3% versus 20% in patients who have responded. Pathological response, if there is any pathological response, if there is in the final pathology, if there is more than 50% of non-viable tumor, basically the tumor, if it has responded, it is a strong predictor of a long-term survival. And biology, KRAS and BRAF mutated patients have highly aggressive disease. ठीक है. So, abhi first we'll study synchronous liver metastasis. In this, we have to consider various factors. First, is the primary tumor symptomatic? Are the liver metastasis resectable? Should we use NSCT? Should we do a 1 or 2 stage procedure, or should we do primary and liver first? So, first, we'll look about there is this paper of managing synchronous liver metastasis. Isme first question that we look out is primary or liver first. So this was the classical approach. इसमें first we used to treat the primary, give 2 to 3 months of chemo and then treat liver. या फिर give 2 to 3 months of chemo, treat primary, give more chemo and then treat the liver. So this is called the bowel first approach. इसमें we used to resect the bowel first of the colorectal cancer and then the liver metastasis with or without chemo during the interval. So इसमें बहुत advantages और disadvantages थे. Advantages थे, there was less surgical time for each operation. Accumulation of risks नहीं होते थे दोनों surgeries के. There was better management of complex surgeries. Tumor behavior evaluate कर सकते थे. Chemo, occult, liver, M1, basically we could treat the micrometastatic diseases with the chemo in the interval setting. And with chemo, metastasis जो है, जो liver metastasis का size था, that was reduced. So that led to a lesser parenchyma resection, higher rates of R0. Evaluation response to chemo हो सकता था, tolerance पता चल सकती थी. Recurrence rate अभी तक हमें नहीं पता था कितना ज़्यादा है. Disadvantages, वही 2 surgical operations थे, psychological effects, longer length as hospital stay, increase in morbidity. अगर interval chemo के time पे toxicity आ सकती थी, that could lead to difficulty in treating liver later on. Interval chemo में liver metastasis गायब हो सकते थे, disease progression and resectability and higher costs. ठीक है, then आया new approach, that was sequential liver first approach, that is called the reverse approach. So first resection of the liver metastasis and later on the colorectal cancer, and always giving neoadjuvant chemo plus minus targeted therapy. So either we could go with chemo plus targeted followed by treating the liver first and then treating the primary. So this was the reverse approach. इसमें the advantages were chemo treatment of liver. So the chemo could treat the liver metastasis as well as the primary. It could avoid progression of the liver metastasis and most appropriate timing of the. So if somebody needed radiotherapy for the rectal part, so it could also give time for that. That we could give chemo for the liver, radiation for the rectum, and then go on to treat the patient. So, and early administration of chemo हो सकता था. We could increase the conversion of an M1 patient to a resectable disease, and it could avoid the palliative surgery of colorectal cancer. Disadvantages इसमें थे that liver progression हो सकता था in patients. जैसे जब तक liver treat करके हम लोग कोलन वाले part पे आए तो हो सकता है कि जो कोलन वाला part है वो progress कर जाए. Although this is rare, but there could be a possibility. And अगर liver toxicity हो सकती है उतने टाइम में, that we have resected the liver first and that led to a further morbidity or liver toxicity.
So what is your experience if liver mets का patient आता है, then you send patient for RT also?
Depends. If it is a colon patient, then we don't send the patient for RT. If it is a rectal patient, then we send the patient for RT. We give chemo first, followed by radiation, then followed by surgery.
If after chemo patient is not responding to chemo that much, मतलब in our setting we are sending the liver mets patient as a metastasis, and we are not sending patient for RT. What other patient, all other people having any experience regarding this? CA rectum with liver mets you are treating.
मैंने एक जगह पढ़ा है, CA rectum with liver mets, short course chemo radiation देते हैं and wait for 8 to 11 weeks. इसके बीच में chemotherapy दे देते हैं और they operate the liver so that meanwhile time will be there for the response in the rectum. Later on they will operate. ऐसा पढ़ा मैंने कहीं. पहले शॉर्ट कोर्स कीमो रेडिएशन दे दो, रेक्टम हील होता रहता है, meanwhile you deal with liver mets. वो रिकवरी में टाइम लगेगा पेशेंट को, यहाँ रेक्टम का भी रेडिएशन का इफेक्ट रहता है फॉर नेक्स्ट 8 to 10 वीक्स।
मोस्टली मैंने वही रिवर्स अप्रोच सुना हुआ है कि आप मतलब अगर मेटास्टेटिक सेटिंग है आप कीमो दो, लिवर रिस्पॉन्ड करता है, देन आप एक बार दोबारा असेस करते हो दैट इफ यू कुड ट्रीट फॉर द लिवर और यू कैन गिव रेडिएशन फर्स्ट एंड देन ऑपरेट।
Okay.
ये भी कर सकते हैं। Meanwhile,
In
rectum will
our setting, we
respond to the
usually
radiation.
not send for RT local treatment for liver mets patient. मतलब सिर्फ कीमोथेरेपी के लिए देते हैं। कीमोथेरेपी के बाद एक्चुअली पेशेंट कभी वापस भी नहीं आते हैं कि हम उनको आरटी के लिए एवेलुएट कर पाए। ओके, एनीबडी हैज एनी अदर एक्सपीरियंस?
एंड ये डिपेंड्स ऑन द फॉन्ग स्कोर। फॉन्ग स्कोर यहाँ पे यूज करके करते हैं क्या पेशेंट को लिवर करना पहले रेक्टम करना है?
अरे वो नौबत
हाँ।
ही नहीं आता है, ये मैं बोल रही हूँ। प्रैक्टिकल में वो नौबत नहीं आता है। लिवर रिसेक्शन के लिए हमारे पास तो नहीं आ पाता है पेशेंट वापस। आइसोलेटेड लिवर मेट्स को हम लोग कीमो के लिए भेजते हैं, पर कीमो के भेजने के बाद पेशेंट अगर आता है और उसका डिसीज प्रोग्रेस ना हुआ हो, ऐसा बहुत कम होता है। अभी तक नहीं हुआ मेरे तो नहीं हुआ 8-9 महीने में। चलो नेक्स्ट लो, आगे कंटिन्यू करो।
So then there is a simultaneous approach. इसके एडवांटेजेस है कि सर्जरीज आर अवॉइडेड, साइकोलॉजिकली बेटर है, सारा डिजीज रिसेक्ट हो जाता है एक टाइम पे, वी कैन स्टार्ट द कीमो अर्ली एंड बेटर ऑन्कोलॉजिकल कंडीशन, मॉर्बिडिटी कम है। ठीक है। डिसएडवांटेजेस है लॉन्ग सर्जिकल टाइम, स्पेशलाइज सर्जन्स चाहिए होते हैं, बावेल एनास्टोमोसिस की सेफ्टी इज हैम्पर्ड, लिवर मेटास्टेसिस का ओकल्ट होना के चांसेस ज्यादा हो सकते हैं, सेप्सिस के चांसेस ज्यादा होते हैं। So अभी तक जो consensus guidelines आए हैं, the consensus guideline says that for colonic primary, one stage surgery advocated नहीं है अगर there is a very complex surgery that is needed, या फिर patients जैसे हमने what I think मोहन was saying is, अगर high risk patients है जिसमें हेपेटेक्टमी बहुत मेजर होगी या फिर सर्जिकल टाइम बहुत ज्यादा होगा, या पेशेंट्स का जो हमने स्ट्रेटिफिकेशन किया है that comes out to be a high risk patient, we will not go for a one stage disease, we'd rather go for a 2-stage disease. Also rectal tumors में हम preoperative radiotherapy is a standard of care, of course in lower rectal and mid rectal tumors, and one stage surgery should not be performed in rectal tumors and high risk colonic tumors. So liver first approach जो we'll study now, so synchronous liver metastasis, this was a study in which synchronous liver metastasis were 3 strategies were performed. First is a liver first approach, then colon first approach और simultaneous approach. और further इसमें 3 groups थे: patients who had a solitary metastasis, patients who had a multiple unilobar metastasis, and patients who had multiple bilobar metastasis. And in each group, patients from 3 strategy groups were matched by propensity score analysis. So first solitary metastasis group में, इस group में the liver first group जो है, so basically तीनों में जो है almost similar survival आया था. So the liver first group had similar survival to both the primary first group and simultaneous group. And multivariate analysis में भी there was no association between treatment strategy and overall survival and recurrence-free survival after liver resection. Multiple unilobar mets में the liver first group had overall survival which was similar to the primary first group but longer than the simultaneous group. So in this, basically if you had multiple unilobar metastasis, they said that you shouldn't go for a simultaneous surgery. You could either go for a liver first or a primary first, but simultaneous will give you bad overall survival. Okay. And third was the multiple bilobar metastasis. In this, the liver first had a longer overall survival after liver resection versus the primary first versus the simultaneous group. And multivariable analysis also confirmed that the liver first approach was a independent prognostic factor in comparison with both the primary first and the simultaneous first approach. Okay. And liver first approach was also associated with longer recurrence-free survival. So second question that we come to is resectable colorectal metastasis में should the neoadjuvant chemotherapy be given? So there is a question that why should we give pre-op chemotherapy in upfront resectable colorectal liver metastasis? So looking at advantages that could be there are, first we'll get to know about the tumor biology, if it is responding or not responding. Second, it can, if the tumor is a little large and it is a little on the unresectable side, it can turn to be resectable if the patient responds. It will treat the micrometastasis. Disadvantages will be if the tumor progresses, it will further deteriorate a resectable patient to an unresectable. The metastasis can disappear. NACT की complications हो गए तो we can फालतू में delay the surgery. Complications जैसे oxaliplatin can lead to sinusoidal obstruction leading to blue liver और irinotecan से hepatic steatohepatitis हो सकता है. So इसको देखने के लिए pre-op NACT in resectable settings के लिए there were 2 studies. One is EPOCH and new EPOCH trial. EPOCH trial में basically they randomized patients into 2 arms. First, resectable colorectal liver metastasis patients who were randomized to FOLFOX के 6 cycles versus surgery, upfront surgery. So in the patients who received, there were 364 patients potentially resectable. Basically, they had less than 4 liver metastases. They looked at progression-free survival. So in this, there was an absolute increase in the rate of progression-free survival after 3 years. That was, the absolute increase was 8.1% in patients who underwent neoadjuvant chemotherapy in upfront resectable setting. And after a median overall follow-up of 8.5 years, the overall survival in the randomly assigned arms did not significantly differ. So basically progression-free survival में difference था, overall survival में difference नहीं था neoadjuvant chemotherapy देने का, अब जो upfront resectable लग रहे थे patients. However, एक आया था new EPOCH trial. So now we know cetuximab जो है, अगर medically inoperable patients हैं, उनमें cetuximab is helpful. So they also tried putting cetuximab in the operable settings, that if the colorectal liver metastases were operable, they further randomized FOLFOX plus cetuximab versus FOLFOX and दोनों में जो है surgery after chemo and chemo immunotherapy के बाद की गई थी. So इसमें there was the findings were totally opposite. इसमें cetuximab add करने का there was no advantage. In fact, progression free survival जो है further worse हो गया था. So progression free survival it was 14.1 months versus 20.5 months with chemotherapy alone, and the study was stopped at predefined futility analysis. So the whole crux of this was that we don't give cetuximab in the resectable colorectal liver metastasis setting. We only give neoadjuvant chemotherapy. So now talking about the rectal cancer. So initial treatment. So the initial treatment decision for colorectal cancer liver metastasis was recommended to consider both the surgical technique of tumor resection and the biological behavior. So neoadjuvant chemotherapy is recommended for those with whom technical difficulties or wherever there is a poor prognosis that is expected. So whenever you think that the patient is resectable but he has a higher risk of disease, always consider for a perioperative chemotherapy. Why? Because the chemotherapy will help in downstaging the disease, it will help in R0 resection, it will eradicate micrometastasis, chemosensitivity will be assessed, and patient tolerability will be also assessed. 5-year overall survival for partial response, the patients who actually respond to tumors are 37% versus 30% who have a stable disease, versus the patients who actually progress on chemotherapy is only 8%. Even the patients who undergo R0 resection after that. So basically resectable high-risk patients who have a colorectal liver metastasis always consider for a neoadjuvant chemotherapy. It can be FOLFOX or CAPOX for 3 months before and after the surgery. Few things that should be looked out for is chemo-induced liver toxicity, progressive disease, absence of survival benefit must be kept in mind before chemotherapy is given. So now this is another
high risk कैसा बोलते हैं उसको?
high risk FONG score से.
FONG स्कोर स्टार्टिंग में पढ़ा था ना, FONG स्कोर स्टार्टिंग में पढ़ा था ना, उससे more than 5 less than 5.
Okay, continue.
So now we'll come to another thing, that is no evidence of disease. versus the patients who have no evidence of disease. So this is a update. So colorectal liver metastases are divided into two categories. That is patients who have no evidence of disease eligible versus patients who have non-NAD eligible based on technical feasibility and loco-regional therapy. So neoadjuvant therapy described refers to systemic therapy prior to surgery for colorectal liver metastases that are initially NAD eligible. Basically, patients whom we know that if we give neoadjuvant chemotherapy, if we take out the disease, there is a possibility that they will not have disease in that. So these are no evidence of disease eligible. There can be a possibility that we give chemotherapy to these patients and they will have no evidence of disease after that. Versus translational therapy is the therapy in which that we give systemic therapy prior to the loco-regional treatment for patients who have colorectal liver metastasis, but we know that these patients will never be eligible for a no evidence of disease. That is, the disease burden is too much for these patients to have a no evidence of disease status ever. So if you have a patient with colorectal liver metastasis and you think that, after giving chemotherapy, there is a possibility that these patients in their final histopathology will have no evidence of disease. There is a possibility. So these will come under NAD eligible. So NAD eligible are further stratified into if they are low risk or high risk, what we just studied. So if we know that the patient is a high risk, we know that we have to give that patient neoadjuvant therapy and further take him for surgery and give them adjuvant therapy. But if we know that the patient has a low risk of disease, we can also take that patient for upfront surgery. Okay. But if we know that the patient can never achieve a NAD status, we give chemotherapy that is called a translational therapy. After giving this translation therapy for 3 months, we will assess this patient again. If this patient becomes NAD eligible, we can think of taking up this patient for surgery. If he still NAD, we will again continue with this translational therapy. Okay. So after all of this, points to note are chemotherapy should be given preoperatively unless surgery of the primary and liver metastasis is very easy. A total of 6 months of chemotherapy is recommended independent of what is given pre or post-operatively. Post-operative chemotherapy can be different to pre-operative chemotherapy and it can be less intense as compared to pre-operative. Okay. Now, for the surgery, now we are talking about rectum specifically. Okay. So we'll ask for 2 questions. Pehla, is the primary symptomatic? And second, are the liver lesions resectable? Okay. So 4 scenarios पढ़ेंगे हम इसमें. First, asymptomatic primary resectable liver metastasis. दूसरा, asymptomatic primary unresectable liver metastasis. Third is symptomatic primary resectable liver metastasis. Fourth is symptomatic primary unresectable liver metastasis. ठीक है. So asymptomatic primary resectable liver metastasis. What we have just read abhi tak is that agar we know that if the patient is high risk, we'll give chemotherapy before surgery. And radiotherapy in the meanwhile, now we are talking about rectum in general. So chemotherapy before surgery will give for liver metastasis, radiotherapy for middle and lower rectal tumors. Okay. Now if we know that the patient can undergo, if it is very easy for the patient to undergo a 1-stage surgery, we can take the patient for a 1-stage surgery in rectum. If we know that the chemotherapy is given, radiotherapy is given, and we can easily resect both of them, we can take them for 1-stage surgery. 2-stage kab lena hai? 2-stage, if we know that there is going to be complex colonic resections, rectal primary mein consider for 2-stage procedures. Major hepatectomy hone wali hai, then consider for 2-stage procedure, and of course high risk patient hai, then take 2-stage procedures. ठीक है. Second is asymptomatic primary unresectable liver metastasis. Of course, we'll give chemotherapy to downside the liver metastasis. Rectal primary hai, for that we'll give radiotherapy. We'll go for surgery of the liver followed by surgery of the primary. Third is symptomatic primary resectable liver metastasis. So primary ko we'll tackle first, that is surgery for the primary. We'll give chemotherapy and then surgery for the liver. ठीक है. And fourth is symptomatic primary unresectable liver metastasis. Okay, so for symptomatic primary, we will operate the patient, that is, whatever is to be considered diversion, या फिर resection and diversion has to be considered. Chemotherapy for the liver metastasis, RT if the patient is having a rectum primary, और अगर patient operable है, तब we'll go for liver first. Okay, now we'll talk about disappearing liver metastasis. So there is a subset of patients in whom liver metastasis totally vanish after NSCT due to chemo-induced compromise. So are these patients really cured? So these patients are rarely cured because PCR rate is very low, that is as low as 4%. And in the disappearing match, the incidence is around 7 to 37%. And if somehow we identify with intraoperative ultrasound या ICG use करके, तो then also surgery identifies macroscopic disease in as high as 17 to 67%, microscopic disease in up to 80% of patients. And how do we reduce this chance of disappearing liver metastasis? We have to avoid over-treatment with more cycles of chemotherapy, and we have to keep assessing after every 3 cycles. So surgery of the liver, we are taking liver first approach if we are taking. So 2 things that have to be kept in mind are functional liver remnant and maintaining inflow, outflow and drainage. Okay. So what is minor and so what approaches can we take? We can either make a minor hepatectomy depending on the disease load. Minor hepatectomy is up to 3 segments. We can do a parenchymal sparing hepatectomy or a major hepatectomy. Major hepatectomy is 4 or more segments. Of course, it has a morbidity which is 20%, mortality 5%. And if somebody asks if there is any difference between non-anatomical and anatomical dissections, so there is no difference in terms of perioperative and long-term overall survival and recurrence-free survival rate. And margins, when it comes to margins, pehle it used to be 1 centimeter margin, but now there's a study which says that 1 mm cancer-free margin is enough, and taking additional margin will not add to any disease-free survival advantage. Okay. Now, if we know that we have a patient who is resectable, he has resectable colorectal liver metastasis, but he is unfit. He has poor performance status, or he has comorbidities, or he's not willing. So what other approaches we can take? We can take radiofrequency ablation, microwave, cryotherapy, irreversible electroporation, SBRT, and high intensity focused ultrasound. ये सारे के सारे इन्वेसिव प्रोसीजर्स है एक्सेप्ट फॉर स्टीरोटैक्टिक बॉडी रेडियोथेरेपी और हाई इंटेंसिटी फोकस्ड अल्ट्रासाउंड. ठीक है, except for these two, all of them will require anesthesia. But evidence of survival सिर्फ रेडियो फ्रीक्वेंसी एब्लेशन का है. माइक्रोवेव एब्लेशन हैज एन एविडेंस ऑफ लोकल कंट्रोल. इन बाकी सब का कोई वो नहीं, मतलब माइक्रोवेव और स्टीरियोटैक्टिक रेडियोथेरेपी का लोकल कंट्रोल का एडवांटेज है, रेडियो फ्रीक्वेंसी एब्लेशन का ओवरऑल सर्वाइवल का एडवांटेज है, बाकी किसी का कोई एडवांटेज का डेटा नहीं है. सो लोकल एब्लेटिव थेरेपी में भी देयर आर सर्टेन लिमिटेशंस. ठीक है, सो साइज मोर देन 3 सेंटीमीटर, nodules of more than 5 in number, and proximity to vessels. If there is a more than 3 mm proximity to vessel, then we have a limitation of utilizing modalities like radiofrequency ablation and microwave. And nodules का जो limitation है, nodules के number का limitation जो है वो cryotherapy में है. RFA and microwave में number of lesions is not a contraindication, but size and proximity to vessels or proximity to colon is a limitation. And local and of course RAS mutation is also a limitation, as we knew that this is a high risk factor. So local cure rates, जैसे हमने पढ़ा था that RFA had overall survival benefit. Similarly, RFA also has a local cure rate of 90%. Microwave ablation we knew had a local control का evidence. RFA से थोड़ा ज़्यादा इसमें local control benefit है, that is 94%, SBRT 90%, with a 2-year overall survival of 70%. So now we'll come to potentially resectable liver metastasis. So potentially resectable क्या होते हैं? 3 सिनेरियो हो सकते हैं कि R0 resection feasible है but FLR will be inadequate. R0 resection possible ही नहीं है due to large tumor, but FLR जो है adequate होगा. And R0 resection possible नहीं है, FLR भी adequate नहीं है. तो अब क्या करना है? So R0 resection possible है but FLR inadequate होगा, तो इसमें हम क्या कर सकते हैं? Portal vein embolization. ठीक है, so portal vein embolization is basically that section of that liver that will be removed, that is embolized with portal vein. It leads to contralateral lobe की hypertrophy. So it takes around 3 to 5 weeks. So there will be an increase in functional liver remnant of around 38% and adequate hypertrophy 96%. So despite this, 15 to 20% will still not be able to undergo surgery due to progression or extrahepatic disease. Complication rates are 0.4%, mortality rate is 0.1%. Second scenario जो what we studied was R0 is not feasible, FLR is also inadequate. Then इसमें क्या करना है? Then we can go for 2-stage hepatectomy. So what is two-stage hepatectomy? So this is basically done that R0 is not feasible and FLR is also inadequate in advanced bilobar liver metastasis. So isme what do? Is we embolize or we ligate the portal vein of the segment that is one of the segment that has to be later on removed. Like in this diagram, what we're seeing is right side has to be removed later on. So we will embolize or we'll ligate. And so left side ke tumor hai, we will do tumorectomy of all of these in the first stage. After 4 to 8 weeks, this left side will get hypertrophied, and right side ka jo hai, after hypertrophy, right side of the liver we can remove. So this is two-stage hepatectomy done for advanced bilobar liver metastasis. 3-year overall survival for this technique is 45% compared to 30% in one stage. And in this also 28% cannot undergo a second stage due to progression of disease in the interval. Third is ALPS, that is associated liver partition and portal vein ligation. So basically, इसमें we will totally divert portal flow to functional liver remnant, and this will lead to massive amount of inflammatory response and rapid hypertrophy. इसमें क्या करते हैं? So basically, the liver remnant that has to be resected, उसको completely we will ligate the portal vein and we will do an in situ split. And जो बचने वाला liver remnant है उसमें tumorectomy कर देंगे. After 1 week we will take out the जो segment हमें निकालना है वो segment हम निकाल देंगे. And 1 week के अंदर अंदर there is more than 30% of total liver का जो है hypertrophy हो चुकी है. So there was also a study which compared between 2-stage and 1-stage hepatectomy for advanced bilobar liver metastasis. They showed that morbidity was also lower in 2-stage, and 5-year overall survival was also higher in 2-stage, and post-op hepatic insufficiency was also there was lesser hepatic insufficiency in 2-stage. Last में है unresectable liver metastasis. So unresectable liver metastasis are the patients whom we are not going to go for surgery. So इनमें we can give conversion chemotherapy or liver directed therapies. Conversion chemotherapy क्या है? So basically we can try to make them resectable. So 15 to 30% of unresectable liver metastasis are the ones which can become resectable later on. So this is called conversion chemotherapy. So this will include patients who have bilobar liver metastasis, or we are not able to receive R0 resection with adequate FLR. So there are various factors, that's a tumor mutation status, patient factors, drug toxicity profiles that have to be kept in view. So conversion के लिए agents that we give are Folfox, Capox and Folfiri. Conversion rates जो है that is 9 to 33% for Folfox and Folfiri. Response जो आता है approximately 50% patients में आता है, but conversion से 33% तक होता है. अगर if we use triplet chemotherapy उसमें R0 resection rates better होते हैं, response rates जो है वो भी better होते हैं, but of course toxicity बढ़ जाती है. So what we learned in New Epoch trial, the addition of cetuximab was not helpful there. But this addition of cetuximab is helpful here in the inoperable setting, that it has led to increased response rate and improved conversion rates also. So cetuximab and panitumumab, or even addition of bevacizumab to doublet or triplet chemotherapy has led to improved conversion rates up to 40%. ठीक है, ये सारी studies हैं which tell about what all chemotherapy agents can be given. So we know that if it is a RAS wild type tumor, so in RAS wild type tumor, we can give that patient Bev along with bevacizumab or cetuximab with Folfox or Folfiri. लेकिन अगर RAS mutated है, then cetuximab का कोई advantage नहीं होने वाला, then we go bevacizumab. RAS mutated है, even then we'll not give cetuximab or panitumumab, इसमें भी Bev देंगे. Right side colonic tumors हैं, right side colonic tumors में भी cetuximab या panitumumab देने का advantage नहीं मिलेगा, we'll give Bev only. सिर्फ left side colonic tumors उनमें EGFR यानी cetuximab panitumumab देने का advantage है. RAS wild type and left side colonic tumors जो कि हम colon में भी पढ़ते हैं. ये सारे trials हैं जो जिनमें ये सारे factors आए थे निकल के. So this was conversion chemotherapy. Second that we'll study is liver directed therapy. So liver directed therapies can be local treatment or loco-regional treatment. Local treatments में भी they can be thermal, non-thermal. Thermal में RFA आएगा, microwave ablation आएगा. Non-thermal में brachy and EBRT आएगा. Loco-regional में आएगा embolic या फिर local chemotherapy. Embolic when we say, so TACE या chemoembolization या radioembolization, that is embolic. And local chemotherapy में there is hepatic artery infusional chemotherapy, ये second line setting में use होता है, या DBIRI, that is basically transarterial delivery of irinotecan coated beads. Radiation based therapy में आएगा selective internal radiotherapy using yttrium microspheres or SBRT. बस यही है.
So I will discuss a bit about brachytherapy, its role and various types. As we know, the goal of brachytherapy is to deliver a high dose to the disease in the cervix and paracervical tissue while preserving the function of adjacent critical structures. So brachytherapy applicators consist of angled or curvical intrauteral tandem devices which match the shape and volume of vagina. Vaginal packing is to be always being done. These packings help the radiation dissipation to surrounding structures. So there are various theories. Initially, they used ultrasound, how to after placing these devices, how to locate are they in position or not. Then after CT was used, but nowadays it is only MRI that is a gold standard for localization of the source of the radiation. So brachytherapy MRI as per guideline is the recommended for the localization before we start the radiation. So we have a delivery options here. Either previously LDR, low dose radiotherapy was used, but then pulse dose came, then HDR came also, depending upon what prefers what. So what is the difference between the three? LDR, that is low dose radiotherapy, is continuous. Pulse doses, as simply name signifies, it's pulsed. And HDR, it is also pulsed regimen, but the difference is these the first LDR is continuous, the pulsed and HDR are pulsed regimes. LDR uses cesium, pulsed, and HDR uses iridium. So in sorry, I have a sore throat. So LDR it is a continuous radiation for 24 means 2 to 3 days. 72 hours days of radiation is to be given, 2 sessions and 2 weeks apart. So in pulsed dose, you can remember the LDR is days, the pulsed is hours, the HDR is in minutes, in that way. So the pulsed one is in hours. It is given in several hours, and the high dose is for several minutes only, because we are giving 10 curies in that in a session. In pulsed dose, we are giving 0.5 to 1 curie. In continuous regimen, we are giving 0.4 to 6 grays per hour. Is that clear? Am I audible and clear till now?
Yes.
Hello?
Yes.
Okay.
Yes.
So this is the bit previous historically how they used. In 1920, they used these tandem devices to match the part to be given. It was Paris 1920, then Stockholm, then Manchester. Nowadays, we are using this ND Anderson device. That's some flesh. I will tell you this 10 devices now, which is mostly used. It is called some Fletcher-Williamson applicator is being used. So, can you appreciate the image? It is from our data only. Is that clear? The image is clear?
Yes.
So in that we have a target. You can see the 2 to 2 centimeter this area. The target is the target area, main tumor volume which we have to target with the device. So there is a European Society Therapeutic Radiation Oncology consortium developed a series of guidelines how to approach, and their approach was only MRI based, which I told you later on. So depending on MRI, they used to map the disease, and they gave this GTV, gross tumor volume, on T2 images. They gave high risk targeted volume and intermediate risk volumes. So here you can see what these three terms are. So you can see gross tumor volume is in the blue. The high risk, that is around it is high risk, and then it is intermediate. Just above it is the intermediate risk of clinical targeted volume. We can remember G, H, and I. A, B, C, D, E, F, G, H, I. Like that. Okay. So these are the three targeted volume. Depending on MRI, we have to delineate. So the high risk gross tumor volume, as we know, that is able to see what is the high risk. High risk encompasses entire cervix and the gross residual macroscopic disease at the time of brachytherapy. Intermediate is just we are given 1 centimeter extra margin where we can suspect micrometastasis. HDR brachytherapy is usually delivered in 4 to 7 treatments spaced 2 to 5 weeks. Again, treatments almost integrated with the course of pelvic EBRT. So this is again the same image. You can see the gross tumor volume, the H high risk clinical tumor volume, and intermediate risk. So as we know, apart from brachytherapy, we have to do interstitial brachytherapy also, which is involvement of placement of needles directly onto the tissues. So apart from these vaginal applicators, the newer applicators come with the different multiple needles which directly go into the tumor and ablate it. So as we know, the radiation therapy is not without complication. Most patients have mild fatigue, mild to moderate diarrhea, which is usually controlled by antidiarrheal medication. Some patients have bladder irritation, which may be symptomatic. Extended field patients have nausea, gastric irritation, low WBC hematological complications. And unless ovaries has been transplanted, all menopausal patients receive pelvic radiotherapy experience ovarian failure. Perioperative complications of intracavity brachytherapy include uterine perforation, fever, and the usual risk of anesthesia. Thromboembolism has been reported, but it is rare. It is with these. In the study of 1786 patients by Ifan et al., reported total complication, whatever comes, whether with EBRT or brachy, it comes within 5 years. After that, the complication rates and the episodes are very less. And even in 5 years, it is the first 3 years which are the incidence is more. So I told the same. Small bowel obstruction, we all know the same, can happen with these radiation treatments. Especially these obstruction is when there is previous history of surgery or lymph node dissection. Most patients who receive definitive radiation therapy for cervical cancer have some local vaginal complications or vaginal atrophy or dyspareunia. So principles of cervical cancer and radiotherapy is that radical radiotherapy is aimed to deliver at least 80 to 90 degree to the point A, which I told you those points are there, because A point is the most area that has a gross tumor volume, and with H, the high risk tumor volume. And point B receives 50 to 60 degree combination with EBRT and brachytherapy. Point A is anatomical, which I have already told you. So indication, I won't go in that. This I already explained. You can read it later on. So there is a study also, Embrace. Embrace is that it is full form I forgot. It is MRI based treatment for adaptive localized chemotherapy, brachytherapy. This Embrace 1 and Embrace 2, I got this from article. They recruited the patients 2008 2015, and later on they provide the results. It's a lot is difficult to remember. If somebody wants to go through, he can go through it later on, but I just posted it for the sake of Embrace 1. There is in Embrace 1 second. In Embrace 1, they didn't included chemotherapy as their part, but in Embrace second study, they included chemotherapy as well as a part of radiation for the treatment of cervical cancers. So treatment of locally advanced disease if in nutshell we have to say, it is a EBRT during first week, second week, these are the cycles, these blue lines in a week, number of cycles, and chemotherapies 1, 2, 3, 4, 5. These black lines are the chemotherapies. After that, we go for brachytherapies. 2 cycles as a 2 if you are do LDR, 2 cycles, 2 weeks apart. Total regimen lasts for 7 weeks. So it is EBRT followed by brachytherapy. As if you are following Embrace second trial, you can use chemo also in weeks 1, 2, 3, 4, and 5. This is a simplified view how to remember the Embrace 2 trial and how to treat locally advanced disease. Hold. Is this much clear? हेलो हेलो
हाँ क्लियर हो गया, पर अभी ये टॉपिक हम लोग के लिए उतना अच्छा मतलब नहीं है.
नहीं है, नो, just a short topic. It was some paper I saw.
नहीं,
One more is there. How to
क्वेश्चन, बट
हाँ,
हम
roll.
लोग रोज प्रैक्टिस नहीं करते ना, इसलिए डिफिकल्ट है.
So short note, अगर कभी आएगा भी रेडिएशन ट्रीटमेंट और दिस थोड़ा सा लिख सकते.
ब्रैकीथेरेपी पे तो आता है क्वेश्चन.
So next is cervical screening. We have time or it's too much now? We can shift it to next week.
अलग बाकी लोग क्या
Hello?
बोल रहे हैं? कोई है भैया, कुछ बोलो. कोई कहाँ गायब हो गए, सो गए क्या सब?
हो गए मुझे लगता है.
कंटिन्यू
भाई सो गए भाई.
कंटिन्यू
और listen, or next week we'll continue.
कंटिन्यू.
Okay. So HPV and cervical cancer. Okay. As you know, HPV virus is very common. With estimate that as many as 4 among 5 women have HP, up to every 50-year-old female, if we see among 5, 4 will be harboring this virus. One of the most significant risk factors for the development of cervical intraepithelial neoplasm and invasive carcinoma cervix. HP is one of the most sexually transmitted disease worldwide and is thought to be most common transmitted disease in the United States. HPV can be identified into 95 to 100% of cervical cancers, making it necessary, though not sufficient, cause for cervical cancers. Persistent infections with HPV genotypes, these are the most common infections, 16, 18, 31, 33, 45, have been implicated in the pathogenesis of cervical cancer. HPV, as we know, it is a non-enveloped, encapsulated circular double-stranded DNA. And it resides in the basal layer of the epidermis of the epithelium, where it resides, and then it proliferates there. And one more thing we have to remember, it secretes these E6, E7 proteins. E6 causes inhibition of 55 and E7 53, which causes the pathogenesis of cancer by various mechanisms. Only thing is E6 we have to remember, P53. I remember it like 6-5, like that, 6-5-3. 7 is related to the RB gene. So, as the human papillomavirus has been demonstrated to be transitory, particularly among younger women, with studies demonstrate 70 to 90% of younger women than 25 years clear the virus. So usually almost every female clear the virus within a year almost. And 16 to 14 years of age, elderly women clear the virus more faster as compared to younger. So how this, in some patients, this virus has to be seen, it resides there. So how some viruses have the property to reside, some mechanisms are there. It minimizes the production of antigens during quiescence phase. So once the virus is there in the quiescent phase, it starts producing less antigens so that the body doesn't respond to them. As the infection processes, viral capsid proteins are quickly shed from the epithelium, where there is low density of antigen. So, as a part of defense mechanism, it sheds uh, uh, these epithelium to have less response from immune. As we know, E6, E7 proteins, they help in propagating and promoting the cancer. As I told, E6 is related to 53, E7 to RB genes. Thereby suppressing the immune response, allowing for the promotion of cancer development. In addition to molecular mechanism HPV to induce cellular transformation, there is recognized clinical cofactors that may contribute. Apart from its own properties to cancer, there are some clinical cofactors like smoking, parity, co-infection with other sexually transmitted diseases, long-term use of OCPs, early initial sexual activities, multiple partners. These, although is a cofactor or propagation of HPV virus to promote it for a carcinogenesis. One hypothesis for this factor is the role of effect of chronic inflammation leading to, as we know, DNA damage and weakening host. Cervical, these are some confounding factors including sexual behavior, age at delivery, other risk factors for CA, cervix. Other studies have demonstrated protective factors for cervical cancer. These are the use of intrauterine devices, have been, and circumcision in males has been promoted. These protective factors. Immunodeficiency, whenever there is a HIV patient, the major cause of CS cervix is because of if there is already HPV there. So this can lead to increased probably incidence of cancer in them. So how do we screen these patients, these HPV patients and these females? What are the screening protocols? So as we know, the goal of any cancer prevention program is to reduce the morbidity and mortality through intervention. So for cervical cancer, current mechanism is to achieve this goal by identifying the carcinoma in situ lesions, which are precancerous lesions. Classically, screening is done by pap smears followed by colposcopic examination. So this is the latest recommendation that has been followed. American and United States Prevention Task Force, American Cancer Society. So they tell according to their guidelines, less than 21 years, we do not need to screen any female patient. In 21 to 25 years old, American Cancer Society, no screening needed, but this task force people, United States, their cytology alone every 3 yearly has to be done. And in 25 20 years, these ACS prefer HPV testing every 5 years. In 36 to 35 years, every female has to be done cytology alone every 3 yearly, or if you are following 5 yearly, co-testing. Co-testing means both pap smear and this HPV genetic testing, E6, E7 has to be done. After 65 years, no screening is needed. I will come back to it later on. Prior hysterectomy, if there no screening is necessary, those without history of, if there is a history of high-grade cervical dysplasia or cervical cancer, no screening is needed for them. This is the pathology, taken a screenshot from the book. You can see there are a bit confusing these terms, but if you look at the diagram, it becomes a bit clear. This is the basement membrane. You can see mild, moderate, severe dysplasia. Actually, there is if you see this, it becomes a bit clear to you. Different classification systems are there. Either you classify the dysplasia depending on the Bethesda system or CIN system, carcinoma in situ system. Both are different, but although the terminology is only different. And pap smear system classification. So if you see within the normal infection, both have considered. I have noted this red box. This is important, and if we remember this part, the rest becomes a bit clear. Before coming to it, if you just look, Bethesda system, there is atypical squamous cells, low grade, high grade. Low grade LSIL, low grade squamous intraepithelial lesions, HSIL, high grade squamous intraepithelial lesions. And these LSIL, HSIL have been divided by CIN system. HPV, mild dysplasias, moderate dysplasias. You can see here we have to cram it up a bit. This CIN1 and CIN2, which one is categorized in which one. It's like that carcinoma in situ 4 is pap smear class 4. I think this, if we remember this table only, that is much more than enough, but a bit dry. I tried to make it a bit simple. If you see, only this red box, this atypical cells of undetermined significance, LSIL and HSIL. 1, 2, 3. 1 has no other divisions. 2 has 2. 2 is atypia and mild dysplasia. 3 is 3. It has moderate dysplasia, severe dysplasia, and carcinoma in situ. So if we concentrate only on this part of the table, the rest is easy to write. I will come back to this picture. You can see the severity of dysplasias. As we go further, from severe, it becomes carcinoma in situ. So what this figure shows us, that it is just cellular disorganization, moderate cellular disorganization, nuclear abnormality, and the more severity it goes.
बोलो
So lesions involving lower third
बोलो
of
ना
epithelium are generally classified as CN1. Those in lower and middle third of this epithelium, CN2. And those dysplasias irregular in third, upper third, it's called CIN3.
ये यार जा रहा है अंदर
So it is just, if we remember these tables, we will be able to comprehend. Low grade squamous epithelial tumors are CN1. It's like that. No need to get
ले
confused.
पाओगे क्या
Once you read this table 1, 2, 3 times, and you just remember it like this, it will become easy
टाइट
to
स्टिच ले
understand.
लो उसके अराउंड और मुझे
So
फोटो
I won't
भेजो
confuse you much. So how to do screening?
नंबर 1
Primary
सिल्क
screening,
से
if HPV screening type 16 and 18 are positive, we go for colposcopy. Others, 12 others are HPV side is positive. This regarding this virus, we do cytology. If there are atypical squamous cells, we do colposcopy, and otherwise it we will do. If there is negative for intraepithelial lesion, we'll just follow them. Is that okay, or I'm just everybody is sleeping now? Let me know. I will stop. Hello.
Continue.
कोई बोर नहीं होता है यहाँ पे फ्री का पढ़ने मिल जाता है
नहीं ये थोड़ा ये it's actually we don't practice it ना, but screening of cervical cancer is an I saw it. Cancer screening and vaccination is a question. Cervical cancer vaccination. So for the sake that we should be able to address, if we write these diagrams, at least we are able to write it. So management of abnormal cervical screening. I won't go into much details. I will just explain the figure. That much is enough. So what they have done some risk stratification. First CIN3+. CIN3+ is nothing. If there is carcinoma in situ 3, means severe grade, there is adenocarcinoma in situ or invasive disease called CN1 3+. Is that clear? So on that they have done risk prediction models. It should be greater than 4%, like that. If you can see the percentage on the right side of those boxes, you will come to know which patient needs what. For example, 60 to 100%, we have to treat the patient. We should not follow the patient, needs treatment. Like 25 to 59%, which needs treatment or at least colposcopy. Okay? The rest down the line needs observation or follow-up, close follow-up. So using risk-based approach, CIN3, which is a severe dysplasia, is considered sufficient risk for necessary treatment for all non-pregnant individuals. Excisional therapy includes sleep, it is that loop, cold knife, conization, and laser cone biopsy, whereas ablation treatment includes cryo, laser ablation, and thermoablation. And other important thing, and this is a very dry one, but if you're okay, I can explain what to do with it. This is simplified view. If there is CI, actually these guidelines they have given for CIN1, CIN2, but I find it's not for us. So among all, I just picked one or two slides to just make you understand. If there is CIN2, that means a moderate dysplasia is there. You can observe if it is less than 25 years. If it is 24 years, about 25 years, you have to do
dual testing.
Screening test every 6 to 12 monthly. Like that, HSIL, they have also given guidelines less than 25, greater than 25 years. And when to do diagnostic excisions. For example, there is high-grade squamous intraepithelial lesion. Okay. Same. If we are planning, for example, there is high-risk intraepithelial lesion or there is adenocarcinoma in situ, if the margins are involved, re-excision is advised, or even hysterectomy is planned if the pregnancy is not planned. If margins are negative, hysterectomy is still preferred, or they can go for HPV-based testing 3 yearly, then 3 yearly interval at least 25 years. Annually first for 3 years. After 3 years, they can go 3 yearly testing. So coming to that question which came in the one of the paper, how cancer prevention or cancer vaccine, how to prevent these cervical cancers. We can prevent it by primary, by vaccine, or secondary. Secondary means early detection and treatment. So these are two prevention policies for the cancers. So primary, as we know, we have to remember two things. There are bivalent vaccines and 9-valent vaccine. Bivalent is Cervarix, 9-valent Gardasil. Okay. So this Gardasil targets 16, 18, and others which I have quoted 31, 33, 45, 54, 58 subtypes of viruses. Gardasil approved can be used for male and female aged 90 to 45 years. So if the age is between 9 to 14, 2 doses are to be given. Greater than 14, 3 doses to be given. Secondary prevention is by, as I told, early detection and treatment. Screening for HPV and cytological smear, pap smear. This is for the secondary prevention, which is for the early detection. Recent studies have suggested primary HPV screening alone versus pap cytology demonstrated greater sensitivity with some loss of specificity for detecting CI1 lesions. Pap smear test for cervical cytology has been key factor in reducing rates of cervical cancer, particularly in high-income countries. Current cervical cancer screening guidelines in the recommendations are to screen women between 21 to 65, which I told below 21 we need not to screen, the guidelines which I showed earlier, and after 65 no female has to be screened irrespective of other risk factors. So what we have to do during the screen every 3 years with cytology alone. Okay. Or if you are doing 5 yearly, then you have to do co-testing. Either you can do 3 yearly, then you have to follow cytology only. If 5 yearly, you have to do co-testing with HPV testing as well as cytology, depending upon what you follow. If woman is greater than 65 years, no prior screening is advised. Okay. I told if the woman is hysterectomy previously done, there is no history of dysplasias, no further pap testing is recommended. But if there is history of some say malignancy or some, then testing will go as per recommendation that every annually or 5 yearly, whatever you prefer. Is that enough? Hello, anyone alive?
They are saying some schedule has been changed.
Regarding?
this vaccination.
Okay, but I checked the latest ACCP. That is there, but schedule I don't know. Schedule I didn't
Schedule
check.
is for 9 to 14 years, it's two doses, 0 and 6. And beyond 14, it is 3 doses, 0, 1, 6.
I checked on
I
book
think
now,
so.
or this what you call this Davidite. It has written this like this. Recent I
Okay.
don't know. Recent is what?
9 to 14 years, I've told 2 doses, na? That is 0
Yeah.
and 6. Other one is 0, 1 and 6.
0, 1 and 6 is 3 dose for.
Beyond 14 years of age.
Okay, 3
Dr.
doses, na?
Anand
Total 3
was
doses.
saying something.
See, WHO has actually updated this dose schedule.
Okay.
9 to 14, 1 or 2 dose. 15 to 20 years, also 1 or 2 dose. But above 21,
Okay.
they have told 2 dose. This is a recent update of WHO on HPV vaccination.
If you
So
have
there is no
some
3
paper,
dose now.
then you
No,
send.
no 3 dose.
Is it same for male and females?
I know only about girls, but I don't know exactly.
Because I tried,
Exact,
only
updated
Devita it
for
has
female.
written like this.
Huh? Sorry?
And Devita it's written, but latest I don't know. Only
This
thing
is a
that
WHO
screening
update.
protocol.
WHO update.
Okay, sir.
Anand, share it, na? Share it in the
I will
group.
share that. I will share that once. I will share that in group.
Okay.
Do we need to go this if screening comes, there is lot of that how to treat this carcinoma in situ first, second, third. This is lot of data there. Do we need to read that also, or it is just any idea regarding that?
फ्लो चार्ट्स डाल देंगे और क्या
वो कम से कम 5-6 फ्लो चार्ट है उसमें. Atypical cells का अलग है. All the simple है only, but find it very boring.
बट ये तो क्वेश्चन है कैंसर स्क्रीनिंग
Yeah, these two are questions. Cervical cancer screening पे भी question है और ये vaccine cervical cancer vaccine पे भी question.
Okay.